Well, talk about like all-star lineup. So now we have Josh Beckman coming up, who's the Executive Clinical Director of Cardiovascular Services and Chief of Vascular Medicine. And you've seen some of the contributions already, always an important conversation. We're going to learn a little bit about, I bet the microvasculature, but vascular health and metabolism. So Josh, thanks.
Thank you. First, again, I want to thank the organizers of the meeting for inviting me. And then I'm just going to say 3 reasons why it's really terrible to go right after Mark Banaka. Number 1, he does a spectacular job in presenting, so you feel a little pressure. Number 2, there was a smidge of overlap in some of the slides. I'll put my own spin. And 3, he showed a picture of me when I was very handsome around 2008. And so I'm immediately a disappointment the minute I stand up here. All right, let's get into this. Some relationships with industry, nobody cares about microvascular disease. We should be safe. I know. All right, so we're going to have a conversation today, and my argument's going to be that PAD outcomes are not really explained by conduit artery disease alone. Microvascular dysfunction is a common pathway driven by metabolic disease, and microvascular function is measurable, modifiable, and should be a trial endpoint. So these are obvious things, but I'm just going to start here. 230 million people worldwide and 8 million people with the worst, lowest estimate possible in the United States have peripheral artery disease. Second most common cause of atherosclerosis, and as we all know, that it's a systemic manifestation of disease. What we don't talk about as much is how bad people feel. And I think this really is the place to start this conversation. So this is taking a look at physical component summary scores of how bad people feel. And we all have an outpouring of empathy and sympathy for patients who have severe heart failure, New York Heart Association class 3, or severe chronic lung disease, either emphysema or emphysema is an example, and you can compare the scores to the average well adult and the average adult. The person with claudication fits right there. They feel awful all the time. Why do they feel awful? They feel stranded. They're not going to go out, they can't go out for a walk, they can't park far away from a supermarket, they can't participate in employment activities like everybody else, they have difficulty with their social interactions, they have difficulty maintaining family things because they're afraid of being stranded. Just imagine walking around and suddenly you have to stop because your legs hurt. And most people, when you just tell them that your legs hurt, they think about that time they fell and hurt their knee and they have to limp for a while. But honestly, this is a disease that impacts every part of your life. Teleologically, this is our ability to ambulate and walk around. And so when you feel this bad, it's a severe limitation. I'm not gonna, these are all things that everybody in this audience knows, but the worst and severest endpoint here is an amputation, and having an amputation just tells you how sick you are and it doubles your rate of death. And so if you ever wanted a reason why we have to take care of patients with peripheral artery disease, we have to take care of patients with PAD, because if they don't and they have an amputation, you can see that over 2 years, half of them are dead. So again, this is sort of focusing on the sickest 1 to 5% of people who are at risk for these events, but we don't want even that group of people to develop and exist. Okay. The other thing I'm going to say is patients are completely unreliable in their ability to tell you how bad they feel. So if we are waiting for people to tell us that they have intermittent claudication, we're already eliminating the vast majority of people that we need to find and we need to treat now. Mary McDermott took a bunch of people from a vascular lab who had ABI-proven peripheral artery disease, and there were 4 kinds of symptom profiles that she described. People who said, I never have symptoms, people who have sometimes symptoms, people who have pain on exertion and rest, intermittent claudication that reads the textbook, and then pain, but they can walk through it. The most important part of this is this part. The worst functioning people are the people who said they never have symptoms. Why is that? Well, they've all accommodated to their disease, and they know exactly how not to provoke it. So they avoid it. And they enter into a vicious cycle of continued disability, and their metabolism and their functional status gets worse and worse. They are sedentary, and when you are sedentary, your muscles get infiltrated with fat. They just can't do what you need them to do. When you're always asymptomatic, it's not because you don't want to walk, you just don't want to develop the pain. And intermittent claudication the rest of these were pretty similar. This pain carry-on, that's probably more lumbar spine disease. This is the same, by the way, for the short physical performance battery. And the always asymptomatic people were at the bottom of that scale, too. It's not quite as obvious, but it just tells you that is the worst form of this disease. All right, so let's start to talk about some mechanisms that underlie adverse functional outcomes. So this was a very nice recapitulation of sort of a big story made into a small story in response to many of the common environmental exposures and toxins. Large vessels on the left, let's see if I can go backwards. Yep. Large vessels on the left develop atherosclerosis, sometimes arteriosclerosis when it's a hypertension exposure, but they develop smaller lumens, plaques, plaque rupture, and for a long time now, the way I've been thinking about this is that conduit arteries cause events. Microvascular function tells you how you feel. On the other side, with the same exposures, smoking, diabetes, all the other adverse exposures that we have routinely, the microvessels actually don't work as well, but they drop out. And so in the claudicant leg, you have fewer capillaries. And your fewer capillaries are farther away from the mitochondria. And your ability to deliver oxygen, nutrients, and remove wastes is impaired. And we'll show you some of that data. And Mike, I'm going to show you how fast angiogenesis can develop, and it's right quick. All right, so the first thing, again, I want to show you is that the ABI is really a bad tool if you want to see how someone feels. And for the cardiologists in the audience, if I asked you, well, this person has an 80% LAD stenosis, how far can they walk? You would look at me like, I have no idea. How would I know that answer? And the answer is large vessel conduit disease doesn't tell you how you feel. So in the portrait registry of 1,130 people, if you take a look at the resting ABI, and basically how limited people tell you they feel, yeah, that's statistically significant. That is a scattergram if I've ever seen a scattergram. This is the post-exercise ABI, so we know that the drop in your blood pressure at your ankle in response to exercise is a bit proportional to how far you can walk, and that's just as terrible. So there is some relationship. I'm not going to say there's no relationship. Of course there's some relationship, but it is not the main driver of how you feel. So again, I want to move the conduit artery closer to events, further away from how you feel. We knew, and these are some of the sort of early studies that made me think that there's something else going on. And this is a study of 1,244 men with intermittent claudication, and they were divided into two groups, people that had diabetes and people that did not. And just take a look across the span of ankle brachial indices with your risk of developing chronic limb-threatening ischemia, represented here by ulceration. And there was a doubling in the people without diabetes as you went from 0.9 to 0.1, which, by the way, is not nearly as much as I thought it was going to be. But at every single level, if you also added on diabetes, there was a tripling of risk. So something else was going on in the patients that had diabetes, in addition to just having arterial occlusive disease. So I began to become interested because we become very interested in microvascular disorders that occur commonly in diabetes, but actually occur really commonly independent of diabetes. Anyone know the #1 cause of microvascular disease in the United States? It's not diabetes, I'll give you that clue. Yeah, it's hypertension. That's where you get kidney disease, right? So this is a nice study taking a look at patients that had microvascular angina. So no coronary occlusive disease at all, thought to have syndrome X. This is the first syndrome X, not the second syndrome X. And then they did gluteal biopsies, and they took a look at gluteal arteriolar function by exposing them to acetylcholine. And what you can see here is that the microvascular angina patients had much worse small vessel function. So 2 feet away from the site of symptom presentation. And again, there are a bunch of studies like this that demonstrate that microvascular disorders are a systemic phenomenon, just like conduit artery disorders are. Here's one of my favorite ones. There are 3 very scary things on this slide. This is the Wisconsin the Wisconsin Eye Group. They look at diabetic retinopathy. Scary thing #1 in young people. If you have diabetes, as your retinopathy severity progresses, your risk of amputation goes up to as much as 5-fold. Scary thing #2, if you're in the older subjects, Your hazard ratio is even worse and goes up to 21-fold. Anyone want to recognize what the third scary thing is on this slide? Old is over the age of 30. Okay. Yeah, everybody here just went, oh my God. All right, so we took a look at the data that was available, and we decided to apply epidemiologic methods to try and figure out how impactful microvascular disease was. We looked at a VA population of 125,000 people, and we did a few interesting things. The VA data set actually allows you to do time-varying analysis. Time-varying analysis means people can change categories. So you may enter the study with neither microvascular disease nor peripheral artery disease, but if you develop it along the way, you move categories, which is why I don't have numbers of patients. I have person years of follow-up. So person years of follow-up basically captures people with the condition they have currently in the data set. There was 11 years of follow-up in this study. And I want to tell you that we defined PAD as basically measured ABI of under 0.9, and microvascular disease was any diagnosis of retinopathy, any diagnosis of neuropathy, and protein in the urine for nephropathy. And what you can see is that with the unadjusted hazard ratio here, when you went from neither to either, microvascular disease increased your risk by 7-fold, PAD by 20-fold, the combination by 57-fold. I will never have another paper where I say there's a 57-fold risk. Even with the adjustments made by everything you can think of under the sun, there was a preserved hazard ratio of 23-fold when you combine them. And it's a synergistic event, and I think we've defined now the patient population in the United States most at risk for non-traumatic amputations. This is the group of people for whom you have to be extraordinarily vigilant. One of the things that people kept saying to me was, you know, microvascular disease just causes toe amputations. Why getting your undies in a bunch? And it's actually not true at all. So if you had microvascular disease alone, you were still at risk for above-knee amputation. And if you had retinopathy alone, you were at risk for the same things. So you could have microvascular disease literally 5.5 to 6 feet away in your body, and you still were at significant risk for having an amputation. All right. So let's just talk now about tiny vessels, capillaries. Muscle capillaries are probably the strongest determinant of how far you can walk. Here's a nice study taking a look at capillary density for peak VO2 on the left. This is work done by Brian Annex's group, and capillaries per millimeter squared for peak walking distance and time. There's a pretty direct relationship there. Capillarization, muscle capillary density, I'm going to show you over the next several slides, is really important. It's a marker of your functional capacity. It's a marker of your metabolic ability. So Brian did a really interesting study where he did 3 biopsies. He did them at rest, at 3 weeks, and then at 12 weeks. And everybody underwent a routine 12-week exercise rehabilitation program. So the first thing I want to show you is exercises on the bottom, and nobody improved in the first 3 weeks, but muscle capillary density increased significantly, and it was only after muscle capillary density increased and then hit its peak that you were then able to improve your walking distance. So the real question is this a mechanism that is specific to peripheral artery disease by itself? And the answer is no. This is a standard mechanism by which the body improves the metabolic efficiency of skeletal muscle. These are all healthy people. This is a meta-analysis of 57 trials, and with multiple biopsies. And what you can see here is that it doesn't really matter what kind of exercise you do. The more you exercise with varying types, the greater your capillary density is in your skeletal muscle. There is a direct relationship between exercise, metabolic function, capillary density, and how far you can walk. So we took all this information and we said, let's see if we can prove it. And a lot of the work I'm going to show you now was done by Alex Sullivan, who's sitting in the back, trying now not to look obvious. And so I will tell you, for those of you who are in academics, one of the most fun things you can do is move institutions. And when you move institutions, You meet new people who think about problems in ways that you have never thought about them before. And you can present them with questions in the way that you think about things, and they can tell you, well, I think about it in this way, and you can bring in new tools and opportunities to study the same questions. And so when I moved to Vanderbilt, actually, I was asked to attend a meeting about lipedema, another terrible problem, and an MRI study, and I joined their group because it was interesting, and I helped them understand the vascular components of things. And then when I wanted to design a study to figure out what's going on with the microvasculature and peripheral artery disease, I engaged them, and it became an extraordinarily productive relationship. So what we wanted to do was to figure out the relative role of microvascular disease in ambulatory function, and so we took a look at the standard things. We looked at resting ankle brachial index. We looked at post-ischemic large vessel blood flow, reactive hyperemia through the popliteal artery. And then we took a look at rest and post-ischemic calf skeletal muscle blood flow, and we created a reactivity index of what happened after cuff release compared to resting. We did that with MRI, and this is what the measurements generally look like. If you take a look on the right, these are perfusion weighted, done with spin labeling, and I'm just going to show you here that there's a bit of higher flow in the PAD patients at rest. You put up the cuff, everybody goes to 0. So we can confirm there's no flow for 5 minutes, and you release it. The blue people are normal, and for anybody who's ever slept on your arm, and then you get up, and all of a sudden you feel like a wave of blood coming down your arm, that's what's happening to the leg. Whereas for the PAD patients, this is the definition of parvus and tardus. It goes up more slowly, it stays up longer, and in fact, we didn't know how long we should be measuring these things, so we measured for 5 minutes after cuff release, and the PAD patients never got back to baseline. It took them a long time. They needed more blood flow for a longer period of time to get back to normal. We also did what's called blood oxygen weighted imaging. Blood oxygen weighted imaging uses the magnetic properties of hemoglobin so we can see which are oxygenated and deoxygenated hemoglobin molecules, and you can take a look at what happens when you inflate a blood pressure cuff. The oxygen level drops, and then you release the cuff, and kaboom, it goes right up in the normal subjects and goes up again more slowly and stays up in the PAD subjects. Harder to get oxygen into the tissues. Okay, so the first thing we did is we took a look at the standard measures to see which of these were a good determinant of how far you could walk. So if you take a look at the ankle brachial index on the left, the reactive hyperemia through the popliteal artery, and the microvasculature alone, each of them had an association with how far you could walk. The fun part was when you put them together, this one drops out entirely. And if you just look at, the relative impact statistically, microvascular function was 4 times as important as the ABI in determining how far you could go. So this is nice association data, but we wanted to see if we could demonstrate some causality, and so what we did was we submitted them. People who were already planned to have revascularization had it. People who were, the others we put through an exercise rehabilitation program. And what you can see here is that the change in the ABI had no relationship to the improvement in walking. The change to the large vessel, the popliteal artery with reactive hyperemia had no association with the improvement in walking. But the change in how far you could walk was strongly associated with the change in microvascular reactivity. And so I think we established pretty well that microvascular reactivity and function is a strong determinant not only of how far you can walk at rest, but also is a measure by which both revascularization and exercise improve your walking distance. And it's not the same mechanism, but I'm telling you there's at least part of a similar final common pathway. Now, some of this work was buttressed by work done by Sanjay Divakaran, who was up in Boston, and Marcelo De Carli's group. And what they did was they took a look at blood flow in the calf, and then they also they did MR SPECT analysis so they could see what happens to phosphocreatine recovery. So the first thing I want to point out is what they saw, what we saw. This is what happens after exercise with skeletal muscle blood flow. And this is the ratio of improvement, healthy, PAD asymptomatic, PAD symptomatic. So the skeletal muscle blood flow has more blood flow over time because they need more blood flow, but their ability to generate phosphocreatine is significantly reduced. So there is a separation between your muscle's ability to function metabolically, either by generating NAD plus versus NADH or phosphocreatine recovery, separated from the blood flow. And so there's multiple hits to this system. Hit number one, you obviously have all the conditions that create ischemia and peripheral artery disease. Hit number two, you have microvascular dropout and impaired reactivity. Hit number three, your skeletal muscle stinks too. And it stinks in its ability to function normally in a metabolic situation and create improvements in walking or improvements in function. Now, I'm going to repeat some of the data that Mark spoke about, and I'm going to talk about it in a different way. So I'm not going to review the results again, except to say there are very few drugs that have you walk further. In fact, this is sort of a grand slam, right? Walk further, feel better, fewer amputations, fewer MACE events, right? It does everything you want it to do. Okay. Here's the Stardust trial. Mark showed you this too. Well, Mark also showed you the leader trial, which I think I have later on as well. What he didn't tell you, and what I think is really key, is that in the leader trial, in this post-hoc comparison, there was no difference in the number of revascularizations between groups. There was no impact on large vessel disease at all, but there was a significant impact in the reduction of amputation. And in this Stardust trial, I can show you that TCP02 increases in the treated group, telling you that there's better delivery of blood flow to the most acral or distal tissues. That's got to be a microvascular effect, because the ABI didn't change here. And the good news is that with liraglutide, I never know how to pronounce these things, the walking distance improvement in a much smaller study that you would never try and get approved for this indication was exactly the same as was seen in STRIDE. So this is becoming more clearly a class effect. You'd have to establish in a prospective trial in a much larger group, but I feel really comfortable in saying this mechanism is really important, and this mechanism we know has a microvascular benefit. Oh, here's the leader trial. Again, amputation significantly down, revascularization no different at all. This is not a large vessel benefit. It may be a bit of a reduction in infection or deep tissue infection. Again, not enough people, retrospective, post-hoc, all those things. But I mean, I have so many papers that look like two lines that are superimposed and are negative. I could recognize a negative result as well as anybody else. So I think we've gotten to the point now where we know that the microvasculature is really important, and I begin to think of the microvasculature as a coupling with the tissue that it subtends. So your skeletal muscle is not working by itself, and your microvessels aren't working by themselves. They are working together, and when your skeletal muscle isn't working so well and it has lots of lipid buildup, it impairs your microvascular function, and you get capillary rarefaction. And actually, we've submitted a paper showing that your capillaries get larger. That's not supposed to happen in nature, actually. We've never seen that in humans, but I'm telling you it happens in PAD. And it creates a functional shunt that makes it harder for oxygen and nutrients to get out. And when your skeletal muscle gets trained, and you do training, you actually get rid of the lipid in your skeletal muscle, and you get improvement in capillarization, and you have a virtuous cycle. So exercise works really well because it actually improves both. Revascularization actually doesn't do much for skeletal muscle metabolism. It does help with the microvessel function, maybe by presenting more blood flow. But in some stuff we haven't published yet, I can just tell you that the amount of oxidative stress that develops after an ischemic response is opposite after exercise and revascularization. So they're not working through the same mechanism, but microvascular reactivity is a really important final common pathway for both methods of improvement. And so PAD outcomes are explained only by events, by conduit arteries. Microvascular dysfunction associates with both walking impairment and amputation independent of ABI. It's measurable non-invasively. There are other tools like non-invasive, like NIRS, for example, spectroscopy. Metabolic disease drives the microvascular pathway. Anybody who's any interest in diabetes knows that. And metabolic therapies improve walking distance in PAD. We've gone both directions now. For me, the research priorities include validating microvascular endpoints in trials, integrating metabolic phenotyping, and building a patient-centered functional outcomes capacity that may also reinforce the different targets that we have to focus on. And with that, I'll say thanks very much for your attention. And I know I'm the thing standing before lunch, so ask me all the questions you want.
Thanks, Josh. I think we see some questions coming in. We have one more session we'll do before lunch, so we'll be good.
Hey, Josh, I've had the pleasure of learning from you at the Brigham and Vanderbilt, and great to have you here. Great talk, both you and Mark. I have a question for you regarding what you brought up with respect to the muscle. Do you think we're doing things wrong in that we're not focusing on the muscle and changing the metabolism? So, for example, you brought up NAD ratio. Should we be doing something different than the vessels? Should we be retuning the muscles with new therapies? And do you see anything on the horizon on that front?
Well, the first half of your question is easy. Yes, I definitely think that muscles are bad. And I think the muscle metabolic flexibility is terrible. And we see this already with buildup of acylcarnitines and other lipid products in the skeletal muscle. The amount of fat in the muscle itself is just much larger, much greater. And so I do think that there's a metabolic disability that we should be focusing on. Now, that said, I don't think I think you need to work on both at the same time. I don't think they're so independent that you could do one and not the other. And I don't know of any particular tonic outside of the GLP-1 receptor agonists that seems to improve metabolism and may also improve microvascular function. I think they move in the same direction, so no matter what you're doing, either better or worse. And so I think the more you improve metabolism, the better you're going to get for both.
I just have a quick question. Do you have any evidence that GLP-1s are reducing the adiposity of the muscle, and we're misinterpreting the muscle loss being,
Yeah, so no, that's a great question. It was published in Lancet Endocrinology and whatever they call that subjournal. They looked at people before and after GLP-1s, and this was done because there was a big fear about muscle mass being lost. And in fact, there was some muscle mass that was lost commensurate with the weight loss, but there was a much larger reduction of adiposity in the muscle than there was loss of muscle. Something on the order of like 4 or 5 times in terms of percentage. So I actually think you're making your muscles far more efficient. Having adipose in the tissue is always bad. I think it's visceral adipose that's living in the tissues. And so the GLP-1s, I don't think make you lose too much muscle, mostly, but I definitely think that they make you get rid of the visceral fat in the muscle far excess to whatever muscle loss there is.
And I can tell you, at least from the regulatory component, there was a very deep dive by the regulators into understanding if there was out of proportion skeletal muscle loss compared to just weight loss with the therapies, and that wasn't present. And it looks like, as Josh has just highlighted, it's certainly loss of both lipid or fat, and then also skeletal muscle, but at the rate that would happen if you lost weight at that amount. There are companies that have anti-skeletal muscle loss antibodies and others going with GLP-1s, so that there might be combination therapies coming that are aimed at trying to keep skeletal muscle. We'll see if they're effective or not. So I'll just highlight that there's a variety of people trying to do that, but the microvascular story, I think, is quite important and may be important for us to think about. Questions? Yep.
Yeah, Josh, for what it's worth, I still think you're very handsome. Also, I mean, we all know kind of sort of conceptually that for the flow, for the perfusion to get to where it needs to go, it's got to pass through the microvasculature, but we don't really have any way of seeing it. It's micro by definition. So, and therefore hard to measure. So 2-part question. One, why don't we see so much improvement in ABI when we have a patient who really takes on the exercise mantle? I would have guessed that if the microvasculature, if ABIs are telling us anything, that we should see some more change. And the second thing goes to your last bullet point on your research initiatives. If you had to guess, and I realize you're a scientist, not a guesser, but the question is, if you had to guess, what's it going to be 10, 15 years from now, we'll be getting an MRI on all of our patients, or we'd be doing a combination of TCPO2 and something else to really understand upfront the disease burden in the microvasculature when they show up and not after they get into trouble.
Oh, two great questions. I think the ABI question is actually easier because I'm a simple man. And so microvessels don't actually go down to the ankle, right? All the microvessels are in tissues. So there are conduit arteries that go from the aorta to the iliac, to the femorals, to the popliteal, then to the trifurcation. And so I don't think microvessels really participate importantly in ABI at all. I think it's a conduit artery measure, and that's perfectly fine. I would really love to understand what's going on in STRIDE. It's the only drug I've ever seen that raises your ABI. No exercise study has ever shown it. And so it's a fascinating observation that I think is a hypothesis-raising question for how that works, and I don't know. Number two, I do think we're going to be taking a look at microvascular function as it's such a synergistic risk for amputation, as an example. We're not going to be doing MRIs in everybody. It's way too expensive. It's a research tool. There are near spectroscopy, which is non-invasive spectroscopy that you can do with a patch. That's not expensive at all. And it's getting really impressive now. There's a couple of publications showing that you could look at tissue metabolism with those patches, and I think we're going to learn a lot from doing that. All that said, I'm really hoping in 10 to 15 years we do have some tools, some tonics that'll improve microvascular function. We may have one now. And then how we measure it, it's going to be a non-invasive tool, and it may end up being TCPO2. I don't know. If I can show that I can, in 50 people, you can change TCPO2, that actually may be sensitive enough to see that there's a significant change. So I'm not going to guess, but there's clearly, people are going to are looking at it more.
We have a couple more questions. I might make one comment, then we're going to go to you, and then Mike. I think you're absolutely right. You know, what strikes me is this story is that the continual, I know they're different muscular tissues, but the continual between what we've learned.
Parallel,
and, yeah, the parallel, right? Is because if I think about what could happen in ischemia reperfusion, until recently we were 0 for 32 in the cardiovascular space in the heart. Every time we open an artery, we try to give it a bunch of stuff, and nothing was better than opening the artery, but people would still have microvascular dysfunction. We went through a bunch of tissue perfusion. We went through TIMI grades. We went through all of the blush scores. And I suspect that if we can get good enough with skin/post reperfusion after holding ischemia reperfusion, that's going to give us a sense. But how we get there will be an interesting technological challenge.
Thank you, Dr. Beckman, for an excellent presentation. JD Shi from USC Vascular Podiatry. Maybe the first thing, I learned that ABI is not really reliable when you have patients with diabetes because of calcification. So why not look into toe pressure instead of ABI as a measure? And I think the guideline for infrapopliteal disease usually will look at TBI. And I was wondering, is it?
TBI is a great measure. I have no complaints with it. I use it all the time when you have calcified vessels and an artificially elevated ABI. Most people use the ABI first. And for the study that we did, I didn't want to include people that had non-compressible vessels. That would just muddy the scientific picture, although not the clinical one.
Mike, and then Hope.
Josh, really thought-provoking. I feel like we found some surprising effects in these drugs that we weren't necessarily expecting, and so now we're digging into it. But I'm going to ask you sort of the flip question, which is the way we often look at diseases, what's broken in that signaling pathway in PAD, if anything? And like, what is wrong? I mean, I get that we see an effect by stimulating these signaling pathways, but is there any data to suggest that there's something broken? And if you, sort of a corollary is, if you take your ways of looking at microvascular disease, which is to add retinopathy, nephropathy, and neuropathy to the definition of vascular disease, is there any omics data that tells you that there's other pathways that are, potentially specific? Because it sort of gets to, maybe we're thinking about the disease incompletely.
So a lot of things in what you just said. So number one, I don't think there's a single hit. I think there's many hits. Number two, I'm not sure that the hit to the microvasculature is the same as the hit to the skeletal muscle. Number three, I think the environment provides enough hits by itself smoking, diabetes, insulin resistance, elevated lipids, abnormal blood pressures, et cetera. Kidney disease, just to make a call out, I think that's really important as well. And so I think that the bigger picture for why some people get rarefaction and some people get atherosclerosis is a much bigger question. I don't know the answer to that. For your other particular question about this disease process in particular, I think there's going to be multiple reasons. I think what's going to happen is that the microvasculature is going to be associated with skeletal muscle metabolic abnormalities. And I'll say for your omics question, there will be some targets that have been submitted for publication that you will see.
Hope.
Yeah, that was read it. My question, you keep referring to these tonics, and we've heard about GLP-1, we've heard about exercise, and I'm wondering if there are other, we've heard about a lot of other pathways sort of in passing today. Are there other targets that you're interested in, and do you think that it's going to be something where we are going to be trying to target microvasculature itself, or the things that are driving the dysfunction?
Yeah, it's actually a really interesting question, right? If you just think about diabetes, and we've not been able to do anything really to reverse microvascular disease at all. So that's not for want of trying. People have been trying to do this for a really long time, and I don't want to make it sound like we're going to come from out of the blue and say, oh, carnitine, that is the magical secret. It's not, by the way. It's been tested. It didn't work there either.
You have some data.
But my whole point is that in some ways, I think microvascular disease, by the time you see it, if you see the disease manifestations, may be too late. And I don't know how to regenerate kidney microvessels, foot microvessels. And actually, the eye problem is overgrowth, not scarcity, in response to hypoxic environments. The best drugs we have are the ones that actually do stuff we never expected them to do, and then we have to figure out how they actually work, and I think we're in that setting now. I'm going to make one case, by the way. I don't think SGLT2 inhibitors have any specific role in PAD at all, and I still believe that canagliflozin causes amputations, and the reason it didn't after Credo was that they held the drug whenever there was a foot problem, until the foot problem went away. The other two, I think, work fine. I use them all the time. But it's only right now the GLP-1s, and then I'm really interested to see if GLP-1 and GIP, for example, are better or not better. And then as we keep we're on our fourth line drugs now with glucagon and then whatever the name of the drug is to preserve muscle. I think we're going to be finding out a lot. I really wish I could tell you there was I definitely think it's grapeseed extract. That's going to be the secret.
I think the SGLT2 comment's an important one for the group because I do think if you think about a class of drugs in diabetics that are certainly increasing infection broadly, GU and others, and so there's at least a signal, maybe a thought. I'll just say one more thing to Hope's question, which is I think we are thinking, and maybe it's the recent talk by Peter Libby, maybe that's what's affected me, but there seems to be much more of a signal towards the inflammatory effects, the inflammasome, so a whole set of therapies are coming in that space that might start to have a role. Josh.
LP(a), by the way. Maybe the same kind of thing, right?
Yeah, may have another multiple one. We'll find out later this year. Thank you, everybody.
Thanks.
Thanks, Josh.